An incidental finding. Obvious lump or bulge could be there. Presence or absence of pain and or dragging sensation could be there. And there could be or could not be tenderness elicited. Modalities for investigation are CT, MR, and real-time ultrasound. Real-time ultrasound has several advantages because we can evaluate the cases in upright as well as supine positions. We can do dynamic maneuvers like Valsalva, compression can be applied there, and real-time motion of contents will be appreciated, which we will see in some clips. So this is the advantage of real time. Can we see this large sac here? And if we move forward, then suddenly with compression, it has reduced, almost reduced. Very little part is there, like this. So types of hernia, they are, right now we are taking up the abdominal wall hernia. So supraumbilical, umbilical, infraumbilical, and esophageal. Linea alba hernias are anterior abdominal wall hernias that protrude through the linea alba. Epigastric hernias occur above umbilicus and they are more common. And they could be truly in midline or little eccentrically placed. Hypogastric hernias, spontaneous linea alba hernia in the hypogastrium are less common because linea alba is comparatively narrower than in the epigastrium. So this is the kind of normal evaluation which we tried yesterday during demos. So this is left rectus abdominis, right rectus abdominis, this is linea alba, this is extraperitoneal fat. At first this extraperitoneal fat protrudes into a sac through the linea alba. This is the one of the commonest presentation. So right now in epigastrium, and then we are evaluating just this is normal. This is normal. We are just evaluating, and when we go in suprapubic area, we will appreciate that linea alba is getting narrower, and at the end, from both sides, the pyramidalis muscles will be coming up. Right here. Yeah. Okay, so this is small epigastric hernia. What we see here, appreciating this is medial edge of right rectus, medial edge of left rectus. This is linea alba. Here is a small defect. What are the contents? Extraperitoneal fat. This echogenic line is peritoneal line. That is peritoneal. So it is extraperitoneal fat which is entering. Linea alba epigastric hernia with cupping and compression, this is initially, and with compression we will see that it is getting reduced. Can you appreciate this? Okay, these are some more examples. Accordingly, I will move little faster. So these are different cases. Do you appreciate? This is small size. This is the neck. This is the sac. Mushroom type sac along this line. Okay, this is another case with trapped peritoneal fluid and part of bowel here because its neck is narrower. Now about diastasis recti abdominis. This case, this is in infraumbilical area only. This diastasis. What we will appreciate, the linea alba is stretched out, but it remains intact. There is no breach in continuity of the linea alba. How do we appreciate? Here, this is the rectus abdominis medial end, and if you follow this echogenic line, we will be appreciating that it is narrower, but it's intact. So that causes diastasis or divarication of recti. In this case, it was only present in infraumbilical area. And this was the size in panoramic view, 42 mm around widely apart. This is another case, diastasis recti abdominis, size approximately more than 5 cm on panoramic view. How do we appreciate? This is right rectus, this is medial edge, and we see here, we focus over here. This is left rectus abdominis, this is the tapered edge. And from here, the entire linea alba is, remember, it is intact in diastasis. This is a video of the same case. We will appreciate this line, this echogenic line, this is linea alba, what is this? Now about this case, this is absolutely uncommon case or a rare case. This is rectus abdominis, this is anterior rectus, this is posterior rectus, and the patient, a male patient, he was insisting that there is a lump which he was feeling mild tenderness was there. This was the defect in the posterior rectus only, but not in the anterior rectus. We appreciate this. And extra peritoneal fat, this kind of fat, hypoechoical fat, this was protruding into the rectus abdominis muscle. This was posterior rectus hernia. But I was unaware of that at that time when I examined the case. Content was preperitoneal fat and the same case with Doppler, and then I studied the literature and I could get to one case in 2014. So this was posterior rectus hernia causing intermittent small bowel obstruction. This was the published report for another case. And thereafter I could get another published case. This was in 2015, spontaneous posterior rectus hernia, a case. About umbilical hernia, they occur through a widened umbilical vein and they can develop at any time during life. This is extended view, how it looks in some cases. This is one example. This is the defect, this is neck, and this is a mushroom sac, mushroom shaped sac. This is now coffin and reducibility. Now what was this? What could be this? Any guess please? It looks a little bit unique. No. So this was P-2 umbilical hernia, and truly 2D view is this. Massive ascites.
Ascites.
The movement is due to patient breathing. Okay, incisional hernias. Incisional hernias are a complication in 4 to 28% of cases, and around 10% of cases undergoing major intervention. The cause is two types: thinning and stretching of the scar. In that case, the neck is wide, little bit wide, therefore they are reducible. And other type is there is a tear in a segment of the scar, and it could be irreducible due to narrowness. Incisional hernia can occur whereas natural hernia means sites of natural weaknesses don't occur. They can occur anywhere along the scar. Many people are looking at this. Small incisional hernia, tibectomy, post-tibectomy. Many cases. I will ignore this. Okay, this is narrow neck, large hernia, post-LSCS. Here is the hernia. So I will move little faster. Another case, narrow neck incisional hernia, LSCS 20 years back. This is one recent case. Oh.
20 years.
Again, a large incisional hernia with preserved parenchymal flow, trapped peritoneal fluid. This is the sac. And with movements, dynamic maneuvers, we are saying reducibility. Another case, on the same line. This is the neck from here to here. This is the neck, and this is sac. We see bowels and trapped fluid. Another case. This is again large hernia. Now this is a case cholecystectomy scar hernia. This is the neck defect and this is the protrusion. This is the sac. When I put the probe, I got this. Thereafter, after some manipulations and evaluation, I could get this defect. Initially, it was this part. This is again cholecystectomy scar hernia. Obvious, so that is clinical. Linea alba, how I evaluate, how I try to understand the anatomy. Linea alba, right rectus abdominis, and here is the defect. Can you appreciate it? Where rectus abdominis is cut while doing that cholecystectomy. So this was cholecystectomy scar hernia. Now appendicectomy scar hernia, linea alba, right rectus abdominis, and here is the defect. It's right now it's reduced. When I ask for cupping, then you will see this white gap. Okay, drainage tube scar hernia. Again, this is uncommon case. We know during interventions, a narrow, small tube is placed, drainage tube. Here is the scar, this is the scar, and when we see, evaluate this is the neck, and this is hernia. So this was narrow drainage tube scar hernia. Spigerian hernias are anterior abdominal wall hernias. They can occur anywhere along the course of this semilunar line or Douglas line, along this line. But usually they occur below. Oh, okay. So Spigerian fascia is the complex aponeurotic tendon that lies between the external and internal oblique muscles, external obliques and transversus abdominis muscle laterally and rectus muscle medially, which we demonstrated yesterday. Almost all Spigerian hernia occur inferior to arcuate line, where posterior rectus is deficient. And Spigerian fascia is penetrated by and weakened by inferior epigastric vessels. This is simple evaluation. How we evaluate? This is right rectus abdominis. These are three inferior epigastric artery with two accompanying veins. This is normal evaluation. How do we evaluate and try to first understand the anatomy? Then we move on to left. This is left inferior epigastric artery with two accompanying vessels, and then we will orient the probe to look for the origin of inferior epigastric artery. Can we appreciate this? Here, this is the, it's coming up. And thereafter, I have tried to evaluate the other side again. So this is classic normal demonstration. And I will ask to do this maneuver. That will determine the site and make our anatomy more clear. So this is right inferior epigastric artery. We appreciate this. This is the origin here. So Spigerian fascia is a complex aponeurotic tendon. We could see this is the Rumax picture. How this looks: external oblique, internal oblique, transversus abdominis, and this is rectus abdominis. And any defect through here, this is Spigerian fascia. So I will ignore this, and this is, I have created this video for along the semilunar line on supraumbilical area because the external oblique, these muscles are more prominent, simply to understand the anatomy. This is external oblique, this is internal oblique, and this is transversus abdominis. This is rectus abdominis, and this is Spigerian fascia. Right Spigerian hernia, one of the older cases, right rectus, bowel with trapped fluid is there. This is the neck and protrusion. Other view. Left-sided spinal hernia. First, we make out the anatomy. We move from linea alba to rectus abdominis to spinal fossa. And that way, then here is that spinal hernia. And we use dynamic maneuvers. This is right-sided. It was little bit difficult. Then I move it here. Here is the defect. It's again reduced. Here is the defect. Now, if I ask to do cupping, now we appreciate this. But initially, it was difficult for me. Accordingly, right-sided spinal hernia, we understand this. This is the sac, trapped fluid, external oblique, internal oblique, transversus abdominis. To make out the anatomy. The same thing in running clips here, rectus abdominis and defect neck fluid bowel. Left-sided spinal hernia, again left rectus abdominis, inferior gastric vessels, and then here is the, when I ask to do cupping, it will be real-time motion of movement can be seen. Okay, I move forward. This is a mass superficial to left spinal fossa. This was a male patient. So he came to me to get evaluated for spinal hernia. But what we see, this is the spinal fossa. Can you see very nice spinal fossa intact in all respects. But there is a mass superficial to this. This is an indicator of spinal hernia. Simply a subcutaneous lesion. Again a mimicker, this mass is within the left rectus abdominis muscle. Again this was a male case. Can we see this is rectus abdominis, this is within, this lesion is, this is linea alba. This is rectus abdominis and here is the mass. Okay, groin hernias include any hernia along, means either superior to or inferior to the inguinal crease, means inguinal